students in Colombo. Because if you are the boss in the unit, and if you don't do it properly, the others will do it the same way that you do. So when you are the house officer in the ward, you have to be there before time, not on the time, not at 8 o'clock, maybe at 7 o'clock. Because when we were interns, the professor of surgery came to the ward sharp 7 o'clock. So we were in the ward by 6:15 because we had to see the patients and we had to know about the patient. So that practice has got into us. So it is built into us. Therefore, we have carried it out right throughout our lives. So please remember, whatever the job, I mean, leave alone surgery. I mean, you might think in surgery only. No. If you are not punctual as the boss or the big man in the unit, others will also be very lackadaisic and do whatever they want. I can see only 243 people have joined by 8 o'clock. Now you are going to start your career. This clearly shows that the rest, who are probably another 1,200, are just doing medicine for the sake of doing medicine and not because you like medicine. If you are doing surgery, you must have the 3 Ds. If not, please don't do surgery. That is the desire to do surgery, the dedication to do surgery, and the discipline. Because most of you probably have done medicine for the glamour. Where you have probably seen in the Tamil or the South Indian films where the patient comes in bleeding with a knife in the neck or stomach, and the nurse takes the patient to the theater and says, "Doctor, patient is ready. You go and operate." Patient comes out of the theater walking. I mean, those are all in the silver screen. That's not the reality. So if you want to do surgery, please be ready to work 24/7. Because you can't leave a surgical patient and say, "I will operate or I will attend to him tomorrow." No. In some other subjects, you can do that. You can put a nasogastric tube, put an IV fluid, and you say, "I'll wait for the investigations to come." No. And everything depends on the house officer. House officer has to maintain that patient in a good condition for the surgeon to operate. And you might think that, most of you have been now studying in teaching hospitals, faculties which have got teaching hospitals. There are registrars, senior registrars, SHOs, and people on second months. But when you get posted to a hospital outside the major teaching hospital, please remember only the boss and you. That's it. Nobody else. So you will be doing most of the work and you won't have time to go and sleep. In the teaching hospital, those who are fortunate enough, who have come up maybe top of the list, might work in teaching hospitals and they will have other people doing their work. But if you get posted to a base hospital or a peripheral hospital where there is only one surgeon, now 2 surgeon stations are also 1 surgeon because of the migration. So you will be working 24/7. Like during our days, even at the National Hospital, there was no accident service unit. There was a surgeon on call on that day, the previous day, had to do the accident service. Only in the night or afternoon, there was a surgeon during the daytime. That was also a retired surgeon who had been employed, who never did any work. And we had to go in the evening and do the work. But in other hospitals, none of them had an accident service. Now, at least you are lucky. There is an accident and emergency unit in almost every teaching hospital where you are going to work. So I'm going to paint the not so rosy picture to you who is going to take up surgery for the internship with the idea of doing surgery in the future. But please remember, the satisfaction you get by doing surgery, I don't think you will get in any other specialty, because patients come moribund. They come with acute abdomens after trauma, and you operate on the patient. Next day, the patient is fine, smiling, and what more satisfaction can you get? So my advice to you is, if you are thinking of doing surgery for money, don't do. Because very few surgeons will have a lot of money. So therefore, do something else. If you want to do surgery, please make sure you do surgery because you like surgery. Now, internship is something that you have to really put your heart and soul and work, whether you do medicine, surgery, gyn ops, or pediatrics. With the training that you get during that time is wholesome. History, seeing a patient, taking a history, communicating with the patient, doing the initial investigations. You are the boss. You decide, because especially outside, I mean, in a teaching hospital, there'll be others to tell you what to do, but outside, you will be the person who is doing all that. So enjoy the work. If you are not happy to do surgery, don't do surgery at all. But now, what are the advantages of doing surgery? Now, for example, if you want to do surgery as a postgraduate career, you have to do at least 6 months a specialty which is related to surgery, where you have to, after your internship of 1 year, you have to have another 1 year post-intern before you sit for surgery part 1. So you have been given 2 years actually to do at least 6 month appointment, something related to surgery. This may be general surgery, pediatric surgery. This may be gynecology and obstetrics, because if you can't get a surgery appointment, but if you want to do surgery in the future, do 6 months gyn and ops, because that is also acceptable. Everybody can't do surgery. So therefore, you are allowed to do at least 6 months of gyn and ops and then apply for the part 1. And why do I say that surgery is a better field? I'm talking now from the internship to the postgraduate studies, because it's not just the internship. You must know what lies ahead of you if you do surgery. Now, surgery MD, once you pass, you get the membership of the Royal College of Surgeons of Glasgow without examination, because the Board of Study in Surgery and the College of Surgeons of Sri Lanka obtain recognition for the MD surgery Sri Lanka from the Royal Colleges about 4 years back, because they came and observed. They saw our standards are higher than the MRCS exam, and this is the only degree in entire Asia where you get the once you get the local degree, you get the degree from the College of Surgeons of Glasgow. What is the advantage? You get direct registration in the United Kingdom to work. Direct recognition. You don't have to do the pleb ball, whatever. And for your post-MD training, all our trainees have got a 3-year job in the United Kingdom, paid posts, not scholarships. A lot of others in other specialties go on scholarships, but you get paid. You get about £4,500 a month for 3 years. You can just multiply it by 410 and see how much it is. It's millions. So at least when you come back, if you come back, you will have a good bank balance where you can buy a property and build a small house if you wish. So please remember, that is the greatest advantage. But getting through the MD surgery part 1 is not easy. It's not easy. So therefore, that is the only age. And the pass rate varies from 20% to 33%. So maximum probably 1/3. So if you are not willing to work very hard, then don't do surgery again. Because halfway through, then you are too late to change over to another specialty. So therefore, please remember, if you are, I'm telling you the advantages of doing surgery, at the same time, the disadvantages of trying to do surgery. But before everything, remember the 3Ds that I told you, and people who follow the 3Ds will invariably end up successful in your career. Now, there is always something about females in surgery. Now we see quite a lot of females sitting for the part 1. In the other countries, there are lots of females who are surgeons. One surgeon who came this time as an examiner is a female surgeon. Tough lady. They are all quite tough. They are very pretty, but they are quite tough. But in Sri Lanka also, I think the trend has started. I think Dr. Minoli will speak to you about females in surgery. And even in part 1 this time, we have seen quite a number of candidates who have been successful. Quite a number. I think unusual number. Out of the females who sat, our pass rate is about 30% altogether, but about 30% of the female candidates who sat have passed. So there is a trend of females also doing surgery, and you will have a lot of competition from the females as well. So I have told you the advantages of doing surgery. I have told you to become a surgeon or an intern in a surgical unit, what it should be like. I don't want to continue talking anymore. So I will stop here now, and I'll get Dr. Gayan Ekanayaka to continue with the speech. And good luck to all of you. You all have gone through a very tough course, which is the MBBS. And remember, you have gone over the first hurdle, but there are many more hurdles for you to cross if you are to climb to the top. But I'm sure all of you have the capability. It is only the dedication, desire, and the discipline that will take you to the top from now onwards. Thank you. I thank the ministry also for giving me an opportunity to address all of you. Gayan, are you there? Hello? Gayan, are you there?
Can you all hear me?
Yes, sir.
Roshan, can you hear me?
We can hear you, sir.
We can hear you, sir.
All right, okay. I'm going to share my presentation. Just give me a second.
Yes, sir. Can hear. Sorry. Can hear, yes. Right.
So my talk today is going to focus on fundamental how to make a surgical diagnosis, how to go about. When I started my internship, it just we felt that I felt that I was overwhelmed with what I should be aiming at when a patient comes to me, because it's just a big jump from being a medical student to be a person who takes decisions. Because as medical students, although we were lucky to get a lot of first-hand work, we had overwhelming task of making a diagnosis. So it's as Professor Nandadeva correctly said that what we how we take care of our patient depends on how we think. So it's a very tough task to actually get the diagnosis correct. So rather than now, because we are in a situation where there's a lot of resource constraints and we are not expecting people to do all the investigations that are possible in the world to arrive at a diagnosis, which is a difficult, which we think is a difficult scenario in our situation, because we are limited by our investigation capacity and also the amount of tests that we should be doing for patients. And how to set about this a diagnosis. Now, best way is to see how the fundamentals of arriving at a diagnosis works for us. The major component that we see is missing, where you type something in a diagnosis card which is not really a diagnosis, which is a problem for us since the diagnosis itself, it should be able to fit with the ICD coding, as you have noted earlier. The ICD coding is the one that actually get all the health data together, and this if you don't have the correct ICD code, and the lot of problems happen, because the allocation of funds and also data collection at the ministry, the central level becomes erratic, where you have where you have in the cards or the BHEs, the diagnosis is abdominal pain, so it is not a diagnosis. So usually what we see is what is missing is key components where the fundamentals are not adhered. Now, how are we going to make a diagnosis? Now, what are the main components of a diagnosis? This was so the thing was very important when we were medical students. When we were medical students, we saw that there were a format. There was a format that was given to us by the Department of Pediatrics. So that gave us a lot of background how to set about making a diagnosis. I'm just going to share the presentation with you. Can I share, Roshan? I'm just going to share this.
Yes.
Can you see the presentation?
I can see, sir. You need to make it full screen and move a few slides.
Okay. Right, I think.
Moving, sir.
So, yeah, so the fundamentals of this taking involves now to make a complete diagnosis in this patient. So you might need several components. This is a tricky condition where you get in the patient coming into the ward or the clinic where there's some growth happening there, and we will see how to make a diagnosis there. So what are the initial components, key components? First one is the anatomy, where surgical diagnosis cannot be made without the anatomy. So if if we say it's appendicitis, it's appendix. So appendix, appendix being so common, there are several other appendices in the body, but this is one of the key appendix. So this, you have the epididymis also, there's appendix, but this is the sort of a bowel appendix. So this appendix is, you don't have to mention it's left or right, because it's only one, or it's usually on the right side. Now this patient, as you can see, it's a left side. You have to name the correct anatomical location. What is the correct anatomical location? What is the correct anatomical location? It's, you can, if somebody says forehead, it's not really correct. So this is actually what we call as the temple, or the region is, or the hairline of the temple region. So so it's very accurate. So why do we need anatomy? Now why we need anatomy is a clear thing that, we narrow down the possibilities of a disease by 90 to 95%. So that is amazing. So if you know the anatomy, if you locate the anatomy, you narrow down the number of possible diseases. So that is very important. Next one is the chronology. Now you need to know what is chronology. Now you need to know whether this is an acute thing, or there are only few chronological classifications. Only one is acute. You have the hyperacute. Can somebody name what is the hyperacute scenario that we talk about? It's also in the acute, but you can say hyperacute. But you don't say hyperacute most of the time. It's in what? Transplant rejection. So it's a hyperacute reaction. So it happens within few minutes. It just gets rejected. So those are not really hyperacute, but they are also acute. But since there is another acute one, they call it hyperacute. So other than that, it's acute, subacute, and chronic. Now, how do we make this decision whether this is acute, this is subacute, or chronic? Can anyone, those who are awake, can someone tell me how do we classify this acute, subacute, and hyperacute business? Anyone? Right. Okay. So acute means generally what we take is acute is within the first week. So acute things are usually within the first week. When it goes down maybe 4-5 days, 5 to 14 days, we call it as subacute, because it's not really acute, but it happens gradually, but within few days. But once it is more than 3 weeks, we call it usually a chronic condition. So this is important in making the diagnosis. It could be the acute pancreatitis, acute renal failure. So those happen within few days, right? So that is important to make sure that your diagnosis carry that component. So next one is the etiology. So etiology is a very important thing, because without having the etiology in your diagnosis, you can actually cannot actually make a diagnosis. So this helps also in the management. So if you say acute the acute cholecystitis due to it's the etiology is not there. So you have to say whether it's a whether acute cholecystitis due to what, because there are several etiologies that can cause acute cholecystitis, right? It can be due to gallbladder stones, or it could be due to overwhelming sepsis. So there are so many other variables. So you have to mention whether it's due to gallbladder stones, or the diagnosis is not really complete without the etiology being present. Next one is the pathology. Now, before going to pathology, etiology, supposing it's a road traffic accident, there is also etiology there. So road traffic accident is actually it's basically a big macro etiology, but actually what happens during the road traffic accident becomes the more important etiology. It may be the patient would have had grazing. The patient had after road RTA fallen down the road. You know, grazing means the dragged on the road. So the graze abrasion. So grazing. So the grazing is the micro etiology, or the friction is the main etiology, micro etiology. So RTA, following RTA, friction injury of whatever the own anatomical region following RTA, right? So you have to mention those things in the diagnosis. Otherwise, the diagnosis is not complete. Because this language of diagnosis is a universal thing. Now, the pathology is universal. So you have several pathological pathologies that we tend to identify as key pathologies. These are inflammation, and you have then you have trauma, you have the degenerative diseases, you have neoplasm, and similarly the disease conditions are classified according to the pathology. So pathology has to be there. Most of the time, we add some words following the letters following the diagnosis. We say itis, OMA. So those are classical add-ons, or it could be indicators to mention something like something related to the pathology. So we say it's itis is inflammation. Now, next one is important is complication. So you have to mention either there are complications or there is no complication. So people have to know what is a complication. So what are complications? Anyone? What is the definition of a complication? Now you need to know what is the definition of complication to say, oh, this is a complication. You can't say in a viral fever, patient having fever is not a complication. If somebody is saying this guy is having fever following viral infection, you can't say it as a complication. So it is not a complication. It is a part of the disease. So how do you define a complication? How do we define a complication? Because this knowledge is not really assessed anywhere. This fundamental knowledge is not assessed anywhere. I know only 300 is logged in, but at least if 100 people get this message across, you will become better clinicians, because then you become aware of your own mistakes in making the diagnosis. No, otherwise there's no one to correct you. Now, when you know the fundamentals, there's hardly any need to correct, because you will be always trying to correct yourself. Either you will ask from someone, or you will arrive at the diagnosis yourself, because there is a guide to making a diagnosis. So this is the only guide to surgical diagnosis as far as we are concerned. Now, before moving on, I would like to share something with you. So I will share you a link to a group which is actually the association of, I'm a member of the College of Surgeons as well as a member of the Association of Sri Lanka Association of Plastic Reconstructive and Aesthetic Surgeons, where the what you call SLAPRAS. So if somebody wants to see, I've just sorry, I have to share this in the chat. So this is the website that you need to go and see these presentations. If you need so if you need more details, so this is so you need to so you need to go to this website and get these details. Now, this is called slapras.com, as well as there is a social media group that I will share that one also. There's a social media group. I will send that link during my presentation, because that is where we share all the frequent data on these key important issues. I will, once it is there, I will just share it with you. Give me a second. Got it. Now, anybody has questions up to this point? Anyone is having questions? Because this is a very important fundamental. Don't have to. We will need to. We will need to know what is important here, because so now this is the link to that. Please join this group, so we'll have more and more updates on these key important topics. Now we'll move on to the diagnosis, key components of the diagnosis again. Now again, the anatomy, chronology, etiology, pathology, and complications. So these are important. Now this, as a short case, if somebody wants to make a diagnosis, now you need to tell the anatomy. This is the angle of the. You can't say it's a lip. So it is more extensive than the lip. So it's actually the anatomy. If you want to localize the anatomy, if you want to write the diagnosis card, it has to be. So it has to be. Usually, it's not the lip. It's actually involving the left side of the oral cavity. So it's it looks like a malignancy. So it came as a SCC, or squamous cell carcinoma. So it's a squamous cell carcinoma of the left side of the oral cavity, extending into the upper lower lip and the angle of the lip. So the commissure, or we call it the commissure. So need to make the proper anatomical diagnosis there. Now this could be anything. So this lymphedema could be anything. Just if you write lymphedema, it doesn't give you anything. So you have to have the idea of it's a left lower limb. It's a chronic lymphedema due to, it could be a congenital atrophy. So it could be filariasis. So if it is filariasis, you say it's filarial in origin. So post-filarial, you can say post-filarial, and then you have to have whether there are complications. So if there is fungal infection, so complicated with secondary fungal infection. That is a complete diagnosis of this patient. So now you know that these patients can undergo lymphomanual anastomosis and almost correct this problem. So lymphatics can be anastomosed to veins. We do that at National Hospital. So we need to know. Then we can actually offer some other surgical treatments for these patients. Now again, appendicitis, we make it. We try to make it. We say appendicitis. It's actually not correct to say only appendicitis. So it has to be where you have to mention whether it's a complicated or uncomplicated, or you have to say whether it's whether there is any other component that is missing. So if somebody mentions acute suppurative appendicitis, that's perfectly fine, uncomplicated, because it means that's a bacterial. So appendicitis could be, usually it's bacterial in origin. But if you have lymphadenitis, or it could be viral, bacterial, so many other organisms and pathologies can give rise to etiologies can give rise to inflammation. So yeah, you need to know if somebody want to make a proper diagnosis. This one is usually what we call, when we can't arrive at a diagnosis, we have what is called differential diagnosis. So you mentioned couple of the possible diagnoses in this one. So someone might say this one is a melanoma, looks like a black thing. It's a melanoma. Somebody might say it's a pigmented BCC, or the basal cell carcinoma, pigmented basal cell carcinoma. So it's actually a pigmented basal cell carcinoma. But if somebody says it could be either a malignant melanoma. So malignant melanoma is it's not a benign condition, it's a malignant condition. Basal cell carcinoma, by the name, so you have to mention what is the region. Now the anatomy is very interesting. Now you have to say whether it's actually the ala of the nose. If just need to Google it, say what are the parts of the nose. It's the right ala of the nose, pigmented basal cell carcinoma. So that is there is a complete diagnosis there, but there are no it's actually uncomplicated, because if the patient doesn't have lymph nodes or metastasis, then you can arrive safely say it's uncomplicated. Now, investigation of surgical disease is another area that we as surgeons, we are very focused how we do the investigation. Now, there are only 5 types of investigations available in the world. So what we believe is that when a patient comes and sits in front of you, you have to make a diagnosis. There are few investigations that you will do to arrive at a diagnosis. So we are not going to order 100 of investigations and see something becoming positive. Surgical diagnosis, surgical investigation. So first one is the diagnostic investigation. So you will pick what is the most helpful one for you to arrive at a diagnosis. So, so as I'm saying, it could be someone can do MRI, PET, CT, and everything, but you are not going to do that to arrive at a diagnosis. So you might do only an ultrasound scan. So supposing patient comes with a breast lump, you are not going to do a MRI straight away. So you are going to, so this is called triple assessment. So one part is clinical, where you palpate the breast and see whether it has some features of malignancy. And then you have to do a basic imaging type, where you can do a mammogram or ultrasound scan, and then you can move on to do a true cut biopsy, where you can get a further diagnostic investigation. But next one is the investigation for the patient and the disease assessment. Now some of the patients. Now, this is where you have to do all the basic investigation, because unless you are going to do any investigate further of that diagnosis, supposing the patient is having just wrist pain, something, and it is due to a strain, and you just do an X-ray and there is no fracture, you are not going to do whether the patient is having diabetes and all those things, because you know that it's going to, if it is a strain on the wrist and you are just going to immobilize it, and that is straight away into the treatment, you are not going to do further testing on this patient. But if supposing you're offering surgery, now you need to assess the patient. So the patient assessment and disease assessment, where disease assessment means that you do staging investigation. It could be a malignancy that you are staging. It could be an infection that you are staging. So now patient assessment is usually the patient's basic investigation, blood sugar, serum electrolytes, ECGs, and everything comes under there. And disease assessment is also important, that you need to see the extent of the disease. Now, next type is the etiological investigation, where you do the where you have where you are going to send some things to somewhere and see whether etiology is correct. So these are usually involving either pathology or microbiology, where you can do finer assessment, where if it is a bacterial infection, you will get a culture ABSC saying that this bacteria is there. So that is something that you will think of. So now next one is for investigation of complications. Now this is very important. So where you pick the complication. Now, as I said, what is a complication? A complication is something that is out of the natural process of the disease or the natural course of the illness. If something in the natural course of the illness, we don't call it a complication. If something that happens out of the, which is not, if say acute inflammation, what is the natural cause? It's resolution. So if that goes into chronic inflammation, that becomes a complication. So that is why abscess formation or something that happens to gangrene, necrosis, that is not the normal disease process. So that is different. Now, other one is a very rare type of complication, where you investigate complications of investigation, because that cannot be classified into one of these things. Supposing a patient comes with a undergoes a flexible sigmoidoscopy, and patient sits up and gets a bowel perforation, and you do a chest X-ray. It's not totally related. It's not related at all to the primary diagnosis, but you're trying to make investigate a complication of an investigation. So that is important to know that as another thing. So investigating this patient with a parotid lump. So you have to make. So first one is a diagnostic one. You will just get an ultrasound scan. That is important, that you make the diagnostic investigation first, and then you can move on subsequently. If you think the ultrasound scan says it's supposing like a malignancy or something, then you have to move further to have a patient assessment and a disease assessment. Patient assessment may be with other biochemical and the other investigations. But disease assessment, you might need to do a MRI. So this is staging. So disease staging, you might need to do MRI if it's a malignancy. And etiological, you might get a FNA of this parotid tumor to get a more clear understanding of the etiology that you are dealing with, or maybe a mucoepidermoid or secondary deposit or something like that. So very important that you deal with this. And if this patient comes with a facial nerve palsy, and then you do a nerve conduction study to check whether the nerve, how much the nerve is preserved. So that is a complication. So that is a investigation for a complication. So that is how these investigations work for you. Now, treating a surgical patient is very important. These are the 5 types of treatment that are available in the world. So it's important. Now you have to, this is easy to remember. There are 5 types of, 5 components in the diagnosis, 5 types of investigations, 5 basic types of treatment, and their sequence. And the sequence is also the same. Patients come to you with symptoms of the pain or something like that. So your symptomatic management is the most important thing. Then you go for support. So if a patient comes with a RIF pain, appendicitis, you giving them pain relief is very important. And then supportive treatments like you are not going to rush the patient to the theater at once. So you have to build up the patients or support patients' physiology. So you support rest the bowel, put IV fluids. So, and the specific treatment being maybe surgery. So that's important. And some of the things like diabetic foot we are talking about primary prevention, and primary prevention of other leg getting a wound, and second prevention of the same side getting another new wound. So those are important classifications, classification of basic types of treatment. Now, if you tick these all the boxes and check whether your patients have got the symptomatic treatment, supportive treatment, specific treatment, primary prevention and second prevention, your treatment is also completed. This is the same way that we assess at the exams. If somebody is going to talk about these 5 components, these are the components that you're not going to miss anything out in the treatment protocols. Now, if you're treating this patient, now it may be a bit too much for you, but just because of time constraint, we are going into so these are some of the short cases that you have to make a diagnosis, whether it's a scarring related or the muscle is not properly repaired. So these are trauma related diagnosis. So this is actually a stretch scar or following laceration, non-sutured laceration. So that's sort of a diagnosis. It's a chronic problem. So scarring is a chronic. Now you have to present what you have got as a professional. So very important that you have arrived. What you write in diagnosis cards may come up when you become a consultant. Sometimes your diagnosis cards come to your admission, and then then you have made a silly mistake, and your interns will be laughing at you. So this is the guy who is teaching us, but no, you haven't even made the proper diagnosis. So these are very important that you stick to basics when your name will be there on a card. We have written the card, so make sure that you do the proper thing. So those are the important aspects that I wanted to convey in this topic, because surgical diagnosis and investigations and the fundamentals of treating. So these are very, very important things. These topics are discussed further in the links that I have given. And if somebody has not received the link, I will post it during my Burns talk later today in the evening. So you should be able to join in those conversations, and also the updates on what you have. And hopefully that you have received the book that we have shared with you, and it's available at the college. That is printed especially for interns, but it's still valuable for your post-intern, postgraduate, and even at the postgraduate exam, we ask those things. Now, I think I've gone beyond my time. I think Sanjeeva is online. Sanjeeva? Professor Sanjeeva Senuratna,
Yes,
Secretary of Surgeons, will talk to you on a very, very important topic. I think it will give the fundamental idea of what we are talking about today. Thank you. Thank you so much.
Okay, good morning, everyone. And thanks, Gayan, for arranging all this. So today I'll be talking to you about pain in surgical practice. Now, as medical students, you would have seen patients coming with pain. So pain is, if you think of it, is a common problem that we see in our day-to-day practice. So what I will try to discuss over next 20-30 minutes with you is 3 different areas, or 3 main areas. One, pain. What does it mean in surgical practice? Why is it important for us? And then how to deal with patients who are in pain. So these are the 3 areas I will try to cover during next 20-30 minutes. So when do we encounter pain, or when do we encounter patients with pain? Three main areas, if you look at it again. Patients coming to the hospital with acute onset pain as the presentation. All of you would have seen patients coming maybe with appendicitis, pancreatitis, cholecystitis, or ureteric colic, etc. Presentation is the pain. They come to the hospital because they have got this acute onset pain. Not that they come with appendicitis. They don't come and say, I've got appendicitis, but they will come and say, I've got acute onset right lower quadrant pain, or in pancreatitis, acute onset epigastric pain, like that. So these patients typically come with acute onset severe, moderate to severe pain at least. Then there's another category of patients who will come with what you call chronic pains. These are patients who have been encountering or experiencing pain for a particular problem over a long period. It is not an acute onset pain, but a pain that had been there maybe for months and sometimes for years. For example, a patient with chronic pancreatitis may come or may have repeated hospital admissions due to these chronic episodes of acute or severe epigastric pain. Back pain is another common similar problem. Third category of pain that we experience as surgeons is patients experiencing post-operative pain. As you understand, most operations will have a incision or a cut, and then therefore, due to that, patient will experience pain. The wound pain will be there almost invariably after each and every operation, although the severity of pain may vary depending on the site and the degree of the operation. Right. So if you look at patients presenting with pain as the presenting symptom, sometimes it helps us make a diagnosis as well. So the type of pain, it's important to understand the features of the pain, onset, and the character, and maybe other features that may help us come to a diagnosis. For example, now somebody earlier also I mentioned about acute appendicitis. Typically, a patient would present with acute onset pain, most initially in the periumbilical area, later localizing to the right lower quadrant. A patient with cholecystitis similarly may present with initial epigastric pain, later on localizing to the right upper quadrant. So this itself will help us make a diagnosis. The type of pain, the site of pain, and the nature will help us to come to a diagnosis. Similarly, patient presenting with acute intestinal obstruction, let's say obstruction of a viscus. If it's a small bowel obstruction, typically the patient will have acute onset colicky periumbilical pain, which may be associated with vomiting, typically a bile stain vomiting. So that again will help us make a diagnosis of small bowel obstruction. Let's say somebody has a bowel perforation. The other patient will, due to peritonitis, will have acute onset but continuous or persistent severe abdominal pain. When you examine the abdomen, there will be guarding and maybe rigidity of the abdomen. Another cause for pain is bleeding. For example, if the patient has been bleeding inside the abdominal cavity due to maybe a leaked aneurysm, etc., this blood will act as an irritant causing pain in the abdomen. So, in addition to that, ischemia. Ischemia may happen due to a strangulated hernia or a torsion of a viscus, and even, for example, non-surgical problem, of course, is a myocardial infarction. There is ischemia of the heart, and that will cause pain. So the pain is the initial presentation in all these conditions due to ischemia or the reduced blood supply of a particular structure. Another situation where we experience or we encounter pain as a presentation is due to an infection causing collection of pus. For example, somebody with a perianal abscess, for example, if you have seen, they come with severe pain around the perianal area due to collection of this pus, which causes tension inside, and that causes pain. Similarly, acute paronychia may be an abscess inside the parotid gland. Wherever there is pus, it tends to cause pain. In addition to the inflammation, there will be additional pain due to the tension that is caused by this pus. So aspiration of pus sometimes or drainage of pus causes or gives an immediate relief. Another thing that we can't forget as a presenting pain is trauma. Trauma wherever in the body, in most situations, would lead to pain. So in addition to other problems that are associated with trauma, pain is also a common symptom at the time of presentation. So you can see how often we encounter pain and the spectrum and the conditions that may lead to pain as the main presentation or an additional symptom. When these patients come with pain, either as the presenting symptom or as an associated symptom, it's important that we manage pain. It's a common misconception that pain should not be managed until the patient is seen by a senior. In surgical practice, in surgical wards, most of the time, initially, the patient will be seen by the house officer. That is going to be you in near future. And other seniors may not be available for sometimes few hours, especially if they are in the operating theater or in the clinic. So you will have to manage the patient for a few hours. So never wait without prescribing analgesics, keeping the patient in pain just because you want the seniors to see before you prescribe analgesics. That should never be done. If somebody is in a pain, severe, moderate to severe pain, analgesics should be prescribed. Therefore, you need to know what are the available analgesics, how to select the appropriate analgesic, what routes are available in situations. For example, if somebody you think is awaiting surgery or somebody like bowel perforation, you cannot of course give oral analgesics. So you will have to decide on an alternative route. Even somebody presenting with a ureteric colic with vomiting, prescribing oral analgesics is going to be useless. So you need to know what are the analgesics. For example, in that situation, the most effective analgesic would be the diclofenac suppository because you are avoiding the oral route and it has a very quick absorption, and that's the standard or the standard analgesic, therefore, that we use for patients presenting with features of a ureteric colic. However, other medications you may avoid which can alter the disease progression. For example, if somebody comes with right lower quadrant pain, if you have a doubt whether this is appendicitis or not, you should not give antibiotics until the patient is seen by a senior and makes a decision whether to operate the patient or not. Because if you start the patient on antibiotic, that will alter the progression of the disease, and patient, when the senior see the patient after a few hours, patient may be different, the situation may be different, and they may not be able to make a diagnosis. However, analgesics won't do that. Therefore, do not withhold analgesics just because you want the seniors to see the patients. So remember, analgesics will not alter the disease progression. If at all, it may lead to more complications if you withhold analgesics. For example, continuous nausea and vomiting can lead to dehydration, electrolyte imbalances, and severe pain itself may precipitate, for example, cardiac ischemia, and they can develop ischemic episodes, even myocardial infarction. So never let patients suffer in pain just because you want them to wait, right? So always consider analgesics as one of the initial things that you would do to a patient who is presenting with moderate or severe pain. Okay, so that is about acute pain at the time of presentation. Then we have this second category of patients, chronic patients presenting with chronic pain, who may have had an acute exacerbation of their chronic pain that has led to the hospital admission. These are typical difficult conditions to manage, right? Typically, we call them surgeon's nightmare, these pains. Example, chronic pancreatitis, maybe chronic occlusive arterial disease like Berger's disease, maybe chronic backache. Because these are conditions which cannot generally be corrected using a surgical modality or intervention, and only the medical interventions or the minimal invasive interventions are the things that are available to correct these pains. So most situations, therefore, we expect help or we obtain help from other specialists to manage these patients' pain. If you have a pain clinic, some of the hospitals, tertiary hospitals or teaching hospitals do have pain clinics managed by pain specialists or anesthetists, then we can get their help to manage these patients. Otherwise, we need to deal these patients' pain using long-standing analgesics, maybe things like opioids, and the combination of other analgesics. Post-operative pain, another very, very important area because we are talking about pain in surgical practice. If you think of the patients that you have seen during your medical student period, you would probably agree with me that it's mostly and it's commonly under-recognized and under-treated. That happens all over the world because we are very quite reluctant to provide adequate amount of analgesia for patients after surgery due to various reasons. Now you can see these are various published studies from all over the world. What they say is at least a third, probably it is far more, the number is much greater in Sri Lanka, experience severe, moderate or at least severe pain during their post-operative period, right? Even at rest, this is while moving, even at rest about 30% experience moderate to severe pain. Over 10% experience severe continuous pain after surgery. So therefore, it's important and a very common problem. You know why it is important? Because it can lead to so many adverse consequences if we don't manage pain adequately. So again, over 80% has experienced some or significant pain during the post-op period. This is a survey among patients who have had treatment in the US or surgery in the US. So it's a common problem, under-recognized and under-managed. Why is it important? Of course, it's humane that we control pain in the post-operative period. Not only that, it may tell us that something is going wrong. Patient may be bleeding, or patient may be developing an infection, or the blood supply may be inadequate to the area, or vessels might have undergone thrombosis, or the bandage or the dressing sometimes, especially in a limb that you have applied, may be too tight. That may be causing ischemia or compartment syndrome. So pain itself sometimes may tell you something is going wrong during the post-operative period. Beyond that, we know pain will amplify the stress response, or what you call metabolic response to surgery or trauma. So these responses will have severe, significant short-term and long-term influences on patients' recovery. For example, we know one thing is when there's a stress response is amplified, they will have increased stress hormones that will increase their sugar levels. So glycemic control may go haywire during post-op period. That can lead to additional complications like wound infections. Beyond that, we know pain causes less mobility, less breathing. Therefore, pulmonary complications therefore are very, very common in these patients where the pain is not controlled adequately. For example, if somebody after laparotomy, if you don't control their pain adequately, they will not get off the bed, they will not breathe adequately. Therefore, there's a much greater chance of them developing atelectasis, pneumonias, and subsequent complications. Similarly, they can develop prolonged paralytic ileus, cardiac events. Lack of mobility can even lead to DVT. Going beyond that, we know sometimes poorly controlled acute pains can lead to chronic pain syndromes. So inadequate pain control, therefore, in the post-op period can not only have short-term but even longer-term problems for these patients. And of course, it delays recovery. Lack of mobility will lead to muscle wasting. So muscle wasting means after surgery, they will find it difficult to move. So their recovery is going to be much prolonged, and it will take a much longer period for them to get back to their normal day-to-day work and maybe their jobs, etc. So there are so many bad consequences of inadequate post-operative pain control. Right. So going on. So why is it important, pain control? Now you see patients will experience less pain, less complications, they will have greater satisfaction, reduce hospital stay. So the cost for the hospital to the health setting is going to be much less, and that will minimize the chance of them developing chronic pain syndrome. So there are so many benefits of controlling pain effectively during the post-operative period. So now we know it's a common problem and that we don't manage it adequately. So what can you do to improve post-operative pain control? And why, if we think, why do you think we are not managing it effectively? Is it because we don't have enough medicines or any other reason? So commonly, what you will find is lack of concern or lack of knowledge. Now, if you know that pain control is not only humane, but it can have so many additional benefits in relation to things that we have already discussed, including early mobility, reducing complications, wound infections, paralytic ileus, pulmonary complications, etc., then you would take a greater interest in managing post-operative pain. And another thing that prevents adequate pain relief is misconceptions and fears. For example, if I ask all of you about opioids, most of you will remember only one thing about opioids, for example, morphine, that it causes respiratory depression. So therefore, among many doctors, there's a great reluctance to use opioids, thinking that it can cause respiratory depression. Of course it can. That's side effects of overdose. That is why you learn the correct dosage. Provided you use the correct dosage, the correct route, the chance of somebody developing respiratory depression is negligible. I can't remember the last time or the situation where I have seen a patient going into respiratory depression due to opioids. So just because you have learned that as a complication should not prevent you from using effective analgesics to control pain in these situations. Right? So remember, effective post-op pain control is an ethical responsibility, and it's a moral obligation that you have to make sure patients do not suffer, and also that their post-operative recovery is enhanced. So they remember, all patients have a right to ask for adequate pain relief. It is not your right to decide whether to give pain relief or not. It is patient's right to have adequate pain relief. They have the right to demand for adequate pain relief if they are experiencing pain. Okay, so what should we do as doctors? What can we do to make sure that we manage post-op pain adequately? So remember that it's a teamwork. All of us need to work together. A team approach is necessary. Not only the surgeons, but the anesthetists, other medical staff, including nurses, all have a responsibility to deal with pain effectively. So what are the things that we can do? One thing that we can do is to tell the patients the type of operation that we are going to do and the type of pain that they are like to experience and what is available for pain control. Sometimes the patients are so scared to ask the doctors, therefore they are not asking for analgesics from the doctors. So make sure that you tell your patients pre-op, especially patients undergoing major surgeries, what is the type of pain they are like to experience and what options are available for pain control. And also remember, one very, very important concept is starting early. Prevention is always better than a cure, or prevention is better than control when it comes to pain. So that is why we have this concept called preemptive analgesia. We treat pain before the onset of pain. So we know surgery will have a pain, will cause pain. So rather than waiting for the patient to develop pain and then trying to treat this pain, we try to treat pain before its onset. So what the studies have shown and what our experience is, always if we start early, the patient will have a less analgesic requirement and the treatment is much easier than trying to control pain or treat pain once it starts. Right? So simple things like giving 2 tablets of paracetamol before the patient goes for surgery is a very effective method of controlling pain during the post-op period, because you are preventing pain during the intra-op and post-op period. In addition to that, during surgery, it may not be directly applicable to you, but we use maybe diclofenac suppositories, local infiltrations with long-acting local anesthetics like bupivacaine that controls post-operative pain. In addition to that, we may use things like epidurals that again will control pain by preventing the onset of pain. And also remember, we need to anticipate and treat. Do not wait for the patient to develop severe pain to start treating their pain. So we know most operations, if not all, will have pain. You have a rough idea how much the patient is going to experience, and therefore from the time of operation as a house officer, make sure that you use painkillers or analgesics on a regular basis. Never write SOS in your prescriptions. So every patient, unless there are contraindications, should be on paracetamol and NSAID. And if you think this is a pain that is not going to be controlled with those 2 medications, prescribe opioid maybe for first 24 to 48 hours. You need to know the dose and the correct route. For example, 0.1 milligrams of morphine given subcutaneously every 6 hourly will control pain in most situations where the patient is experiencing severe pain. Only don't worry about respiratory depression. Only worry is patient may be a little drowsy. Therefore, the mobility of patient may be reduced. We have discussed about the importance of early mobilization. So it's about striking a balance between adequate pain control and keeping the patient awake. So therefore, you can mobilize the patient with adequate chest physiotherapy if you are expecting the patient to develop pulmonary complications. So it's balancing. But having said that, pain relief probably is a more important thing, because even if the patient is awake, patient will not get out of the bed if the patient is experiencing severe pain. So make sure, therefore, you give adequate pain relief. So patient education again is an important thing. You need to tell the patient what are the methods that are available. You need to make sure that you use tools to assess patient severity of pain. For example, you can use visual analog scales or a score of 0 to 10. Ask the pain how severe the pain is, and also that will tell you whether your treatment has improved the patient's pain. You will have a rough idea. And you need to tell the patient, okay, this is why it's important to treat pain, and make sure patient is also part of your pain management. There are so many different options that are available when it comes to pain management. So remember patient factors, anticipated degree of pain, drug profile, efficacy versus safety. We know some drugs have side effects, especially if the patient is a long-standing diabetic with marginal renal functions. You'll be careful about using NSAIDs. Patient with asthma, you may not be able to use NSAIDs. So you need to know the drug doses, side effects, frequencies, all that is important. And also availability. In our context, all the medicines may not be available on a regular basis. So in case certain medicines are not available, you need to know what medicines or alternative medicines that you can use in such situations. Especially if you are thinking of interventions like local blocks, epidurals, etc., expertise also becomes a problem. Therefore, you probably will have to ask for expertise from a senior or a colleague. So when it comes to pharmacologic agents, I'm quite sure you know all these ones, all these medicines. We have the paracetamols and NSAIDs. Gabapentin or pregabalins are again another category of drugs that are used on a fairly fairly commonly. Then we have other weak opioids like codeine, tramadol, or what we call Panadine, that is paracetamol combined with codeine. All these are available. Strong opioids, commonest drug that we use is morphine in our context. It's far better than pethidine, because pethidine is given intramuscularly, morphine is given subcutaneously, less painful. So morphine is out of the strong opioids, morphine is the preferred post-operative pain analgesic for post-operative or pain control. Other option is to use a short-acting opioid, fentanyl, but the action is very short. Therefore, it is not the preferred strong opioid to manage post-operative pain. Then additionally that we have other adjuvants like ketamine that is freely available. We can use oral ketamine as a fairly effective analgesic agent where the patient's pain is not controlled with other medicines. So we have several options, oral route, then we have other routes. IV paracetamol even is available in case the patient cannot take oral paracetamol. We have already discussed about local infiltration, peripheral nerve blocks, quite effective. For example, if somebody has multiple rib fractures, this is one of the most effective treatments to control pain. So these other methods like ketamines, NSAID, paracetamol, local blocks, etc., will minimize the requirement for post-op opioids, which we don't like to use much, especially after abdominal operation, because it causes paralytic ileus, prolongs paralytic ileus, and may reduce patient mobility. Okay, so this is the last slide. So the take-home points, these are the things that I want you all to remember. Pain is a common problem. It's a very common problem in surgical practice. Every day we encounter patients either presenting with pain or experiencing pain after our surgical interventions. So it has numerous benefits. If we can control pain adequately, it has so many benefits, short-term and long-term. So how are we going to deal with it? Have a strategy and plan early. So you need to know, especially patient undergoing surgery, discuss with the patient, discuss with your team, and have a plan for the management of post-op patient of each and every patient. Start pre-operatively, use preemptive analgesia judiciously, and make sure that you revise your pharmacology, read about the medications, drug side effects, contraindications, cautions, and the doses, frequencies. All this is essential knowledge for a house officer. And don't be scared to use morphine if the patient is in pain. Don't worry about respiratory depression, provided you use the correct dosage and you can monitor the patient, don't worry about respiratory depression. Okay, that's all I have to say about pain in surgical practice. So next time when you see a patient, when you become a house officer, make sure you start thinking about pain actively. Think about pain and manage pain effectively. So if there are any questions, we can spend hopefully a couple of minutes to answer any questions that you have. Thank you.
That was Professor Sanjeev Siniviratna on management of back pain and pain management. So thank you very much, sir. So next up is a lecture by Dr. Nisanka Jayawardena, consultant surgeon at National Hospital, Colombo. Over to you, sir. I think sir is locked in. So next lecture is surgical abdomen by Dr. Nisanka Jayawardena, consultant surgeon at National Hospitals, Colombo. So can you hear?
Excuse me, this is from the College of Surgeons. Dr. Nisanka won't be joining in 5 minutes. Dr. Ramdi Bananayakar will be joining.
Are we getting the lecture now, or shall we take a break?
Hello, can you hear me?
Yes, can hear Dr. Andiman Nanaka. Yes.
Hi, Roshan.
Hi,
Morning.
hi. Good morning. Yes.
Okay, I'm going to talk on two topics, and I'm going to have them say consecutively. The first topic will be on peritonitis. Are you able to see my screen? No. Can you?
No, you're not sharing it.
One second. Share screen. Share.
Yes.
Should be all right now, no?
Yes.
Yes, we can.
Okay.
Randima,
Yeah, hi, morning, guys.
Yeah, hi. Thank you for joining. And if you can touch a little bit basic on the abdominal analysis of abdominal pain also at the same time, that will be great, because Dr. Nisanka Jayawardena has fallen ill and he can't do his talk.
Really?
Just,
Okay.
Just on.
So yeah. So I wasn't prepared to talk on abdominal pain. Anyhow, just I suppose for a house officer and intern, this is an important area. So we frequently get patients during casualties with abdominal pain. And now, if you record patients with abdominal pain, the instances we get the acute abdominal pain and the chronic abdominal pain patients. The patients who are like come into the casualty, they can be divided like this. And then also we have patients who are having abdominal pain post-operatively. So these are special entities that we have to sort of consider when we are managing patients. So abdominal pain, there are 9, as you know, there are 9 quadrants in the abdomen. The pain can be arising because of a pathology within the abdomen in any of those 9 quadrants, or maybe 1 or 2 quadrants, or the entire abdomen, the whole of the entire peritoneal cavity, like in my next topic, peritonitis. So the patient, the area where the patient is complaining, maybe right hypochondrial pain, if the patient is having maybe cholecystitis, or the patient may be complaining of central upper abdominal pain when the patient is having pancreatitis. Likewise, the anatomical structure in that particular quadrant may be the cause where the pain is. And the other aspect is where the patient is having referred abdominal pain. Like, for an example, the patient may be actually having maybe lower lobe pneumonia and causing like inflammation at the diaphragmatic area, and the patient is actually complaining of lower abdominal pain. This is not a common occurrence, but it can happen. And sometimes the patient is having acute appendicitis, and the initial period, the pain is actually referred to the umbilicus, and the patient complains of pain in the umbilicus. Likewise, sometimes ureteric colic pain, although the colic is inside, the stone is inside the ureter, the pain is referred to the testicles in the males. So likewise, there can be referred pain to and from the abdomen. So these are things that you need to consider. So when you come across a patient with pain, first of all, you must understand what you should be able to judge why the patient is having the pain. It may be because of a trauma. So in that case, you may have to actually attend to the patient's airway, breathing, circulation, these factors before you attend to the abdominal pain. But if you leave aside all of that, and just purely concentrate on abdominal pain, you need to go through a proper history. We'll have to ask, like, when did the pain start? And the severity, you can give a scoring from 0 to 10, and you can ask the patient, like, pain is subjective. A severe pain in one patient may be, mild to moderate in another. So you have to be aware of this as well when you're considering pain anywhere, not only in the abdomen, anywhere in the body, even a headache. So you go through a thorough history, like when it started, whether there are any precipitating and aggravating factors, and whether there are any relieving factors. Abdominal pain, for an example, the patient with a gastric ulcer and a pain in the upper abdomen will say after meals, my pain is kind of less, but in the duodenal ulcer after meals the pain can be increased likewise. And the patients with pancreatitis might feel relieved of the pain if they sort of bend forward. They are in a sort of a crouched up position because of relief. So these things are also important when it comes to taking a history of a patient with pain. So you can then can I say so if we have to take a few examples if you're like managing a patient with abdominal pain, and I would just give some example, like pancreatitis, or for an example, biliary colic, a patient having stones in the gallbladder and causing pain. So these patients might complain of pain, particularly after a fatty meal. And so you have to be you have to have a wide knowledge. You need not have a depth in knowledge, because you're not going to manage the patient completely. You are going to manage the patient's initial phase, where you will give the patient analgesics, resuscitate, hydrate. If the patient's having maybe an inflammatory condition inside the abdomen, you can take blood and urine for culture and start empirical antibiotics. So and so management of pain, not only in the abdomen, everywhere else, there is a pain ladder, WHO pain ladder. I don't know whether this is covered in any of the other topics. So there is a pain. So simple abdominal pain, you can give a couple of paracetamols. And if you suspect the patient to be having upper abdominal pain and it is probably due to gastritis, you can give the patient some proton pump inhibitor. Or if the patient's having an inflammatory condition where they are, I'll be covering that area in my next topic, peritonitis, you can give the patient a stronger analgesics in the form of opioids, starting with morphine, pethidine. And if you are suspecting any other pain, maybe ureteric colic and all, if the patient is not having renal failure, you can consider giving non-steroidal anti-inflammatory drugs either orally or rectally. So you have to actually, again, look at the patient's condition. If the patient is vomiting profusely, giving oral analgesics is a problem. So you may have to go for parenteral. Parenteral means, other than oral, you can give it either rectal or intravenously. So actually, I was not prepared to talk on this topic. And so anything you want to ask about management of abdominal pain, anybody, you can, unmute and raise the question, and then I can address that. Oh yeah, and management of chronic abdominal pain. Sometimes, patients will have chronic conditions in like chronic pancreatitis, where they have recurrent abdominal pain, maybe after a binge of alcohol, and they get admitted to the hospital. So these are special scenarios. And then patients having mesenteric ischemia, where they have atherosclerosis of the aorta and the superior and inferior mesenteric vessels, and they may have abdominal pain after meals likewise. So there are special conditions. And there may be patients who are coming with vague abdominal pains, like, they maybe have, a malignancy inside the abdomen. They might say, I have a little bit of pain after meals, I feel bloated. So they may be the pain, pain is something that people describe in different ways. They might say, I have a sort of a stabbing pain, a colicky pain, or a dull ache or a drag like thing. So these are some of the symptoms that, the ways they describe pain. So we have to understand that there's a chronic element and is an acute element. Particularly these acute patients may be having severe inflammatory acute conditions in the abdomen that you must not miss. So you need to see a lot of patients. Now, during your internship, you will have a lot of patients to see. Don't wait without examining them. Thoroughly examine the patients. Take a good history. This is a good opportunity for you to have a very good platform for your future career. Examine the patients, take a history, and you will gradually learn the skill of diagnosing the patients with acute abdominal pains, different conditions of the abdomen. These things don't happen overnight. You have to practice these things, like if you take like anything else in life, maybe a sport, maybe a dancing, whatever. You have to practice with the patients. Just because you read the books and you just pour your knowledge in, it doesn't mean you will be able to manage these patients. So please spend time with patients. So I'll now start with my topic. If you have any questions, please unmute and ask me during or after my presentation. So what is peritonitis? First of all, to tell you what peritoneum is the inner lining of the abdominal cavity. It is a large serous membrane. So it has an areolar connective tissue covered with mesothelium, a single layer of cells, squamous cells. These are not the keratinized cells we have on skin, but this is a mesothelium, a monolayer of specialized pavement-like cells. These are sort of flat cells lining the inside of the abdomen. And there's two layers, which is parietal peritoneum, which is lining the inside of the anterior and the posterior abdominal walls, and the visceral peritoneum that envelopes the organs like liver and then the bowel, so on and so forth. Certain organs are retroperitoneal. They are not having a full cover of the peritoneum. Like the pancreas, only the anterior surface is covered by the posterior parietal peritoneum. And the kidney is only covered anteriorly by the posterior parietal peritoneum. Likewise, the posterior part of the kidney doesn't have a parietal peritoneum or the visceral peritoneum. So the function of this peritoneum is it keeps the peritoneal cavity lubricated. It secretes a peritoneal fluid. So these are images from the internet where these patients have had perforation of a bowel, small bowel, and leakage of bowel contents, leakage of anything like bowel, bile, feces into the peritoneal cavity will cause an inflammation of the peritoneum leading to peritonitis. And on the right-hand side of your image, it's the fibrinous material that forms due to a body's immune reaction. And these things actually stick to the organs. Particularly if you see a patient opened up for peritonitis, you will see frequently this fibrinous, proteinous material stuck to all over the peritoneal cavity and the bowel. And so we need to clean this up. Sometimes we can't completely remove all of this, but then the body's defense mechanism will remove this stuff through macrophages once the perforation or the culprit is curtailed. Okay, so sometimes this peritoneal, the inflammatory conditions can be within the bowel, like as shown in the picture, may not be in the entire abdominal cavity. So definition of peritonitis is an inflammation of the peritoneum, inner lining of the abdomen that also envelops the viscera. So peritonitis, it can be localized to a certain area or like a certain quadrant of the abdomen. For an example, acute appendicitis causing local peritonitis, the pain and inflammation, tenderness and all of these symptoms, signs and symptoms are localized to the right ilia fossa. The rest of the abdomen is generally soft and non-pain. For an example, cholecystitis, the patient will have a positive Murphy sign because of the inflammation of the visceral peritoneum or the around the gallbladder. And when the fingers touch the gallbladder, you all should know how to elicit the Murphy sign. Read about it, and then that is because that area is inflamed. So that is localized. Generalized, of course, it's a different scenario where the patient will have tenderness, maybe associated with guarding and rigidity throughout the abdomen. For an example, if there is a perforated gastric ulcer and the leakage of gastric contents into the peritoneal cavity, the whole of the peritoneum will get inflamed. There will be pockets of pus in the pelvis, in the paracolic gutters, and in and about area. Say, for an example, if it's a posterior perforation in the lesser sac, if it's anterior perforation in the greater sac, likewise. So this peritonitis can be infectious and non-infective. As I said, a chemical peritonitis due to bile, pancreatitis. Pancreatitis is usually a sterile inflammation. It doesn't have an infection. So these are non-infective causes of peritonitis. So there's another term which is frequently used associated with peritonitis, that is peritonism. It is not the same thing. It is in peritonism there is an actual there is no actual inflammatory process. For an example, hemoperitoneum. A young female who has a tubal pregnancy, a rupture of a tubal pregnancy, will have blood seeping into the peritoneal cavity, a hemoperitoneum. And these patients will have peritonism. That is a irritation of the peritoneum. It mimics peritonitis, but it is not. You know, with experience, you will be able to differentiate between peritonism and peritonitis. During my internship, I can remember there was a young female who was admitted to the surgical ward following a ruptured ectopic. Luckily, on that day, I realized that, you know, this is not peritonitis. So I immediately called my surgical SHO and the gynae SHO as well, and they managed to save that patient. So this is something that you need to keep in mind. Just because there is a little bit of tenderness, you should be able to subtle difference between peritonism and peritonitis, where might be crucial in saving a life. So there are various types of peritonitis: primary or spontaneous bacterial peritonitis, which we'll talk later. Secondary, this is because of an intra-abdominal pathology. And tertiary peritonitis, that is persistent or recurrent after treatment. If the patient presents with gastric perforation, you go in, clear the contents, and then you repair the defect with a Graham's patch, and you come back. Then there is continual leakage. There is no healing, or maybe because there's a gastric tumor, it has perforated and it is leaking still, and then that is tertiary peritonitis. Of course, this is not really important, but what you need to understand is the common variety is the secondary peritonitis because of an intra-abdominal pathology, an inflammatory process. And then there is this peritoneal dialysis associated peritonitis. A word about spontaneous bacterial or fungal peritonitis. Development it's despite the absence of an obvious source of an infection. So the patient develops pus in the peritoneal cavity, but there is no obvious source of an infection. Usually this happens because of an infection of the ascitic fluid. These patients may be having what do you call this, liver failure and ascitic fluid, and then infection of the ascitic fluid, they develop this spontaneous bacterial or fungal peritonitis. Diagnosis is by paracentesis. Paracentesis is you put a needle and a syringe and you aspirate, send the you of course aspirate pus, and then you send that for culture. You may have to drain it either laparoscopically open or radiological guidance. So usual organisms are gram-negative organisms. Those are the gut organisms. Maybe because of gut, they transmigrate through the gut wall, and maybe the cause of the infection. E. coli, Klebsiella, and maybe Streptostaphylo organisms. And generally, we start empirical antibiotics, a broad spectrum empirical antibiotics, and then depending on the culture report which we receive in about 48 to 72, about 2 to 3 days later. Of course, as a house officer, one of your duties is to trace the culture reports. This way, you can't just say, no, it's not available. You have to actively, not only in this country, globally, you need to actively go and trace the reports or discuss with the microbiology team. There may be, medical officers, registrars, senior registrars, may even be the consultant. Just say this patient is on antibiotics. Have we got a preliminary report or on what the growth is? If there is, they might say, okay, the antibiotic you're giving probably might not help. We are growing a different organism, so shall we change the antibiotic? So these subtle, these not subtle, what I may say, little things can, help the patient in a great way. Ultimately, you all are being doctors. You all are going to help the patients. Okay, so there is a place for infusion of albumin for these patients. So when you come across these patients, particularly in the medical ward, you will be managing them. These are generally not. This is not a surgical entity usually, unless it requires laparoscopic or open drainage. Secondary peritonitis, perforated hollow viscous appendix, peptic ulcer, diverticulitis. These are common surgical presentations. If you're doing a surgical catcher, you get one of these three most likely in one of your on one of your day, at least one of them, or maybe all of them sometimes. And pelvic inflammatory disease, particularly in the females. And following trauma, there can be a stab injury and then gut perforation causing peritonitis. Iatrogenic perforations. This is a frequent occurrence. It may be because of surgeons or maybe gynecologists doing an operation. Gynecologists, they do pelvic operations with laparoscopy. They don't see a bowel injury, maybe cautery injury or a sharp instrument injury or a trocar injury, something like that, and it goes undiagnosed during the surgery. And then during the post-operative period, the second day, the patient is spiking temperature with severe abdominal pain and tenderness, abdominal distension, vomiting, fever. These will be the signs and symptoms in that patient. And of course, anastomotic leakages, a nightmare for any surgeon. I also have had anastomotic leakages where, we do an anterior resection, high anterior resection, we put the bowel together. We hope that the bowel heals well, but eventually it leaks. There are many factors that can give rise to an anastomotic leakage. So it's not only the surgeon factor, the patient factors, patient's nutrition and all of that. So patients will leak. If a surgeon says he has not had an anastomotic leakage, that is not true. Almost all surgeons have had, almost not all surgeons have had anastomotic leakages. So this is something you will see during your internship if you do a surgical appointment. Diagnosis, it's primarily clinical. For an example, the patient will say, I'm having severe pain, tenderness. You just take a history and you examine the abdomen. The patient is having severe tenderness with or without guarding, rigidity. And this is typically a surgeon will immediately diagnose peritonitis the moment he lays the hands on the patient's abdomen. Then, of course, biochemical tests. What are the tests we do? Frequently, we do the full blood count. For most patients, we do full blood count. Then something we can do is CRP, that is C-reactive protein. These, the levels of which increases in acute inflammatory conditions. And it's a very good tool, that and the full blood count, particularly in the patients who are having immunosuppression. So I come across these patients, particularly the patients who have had cancer and chemotherapy for that. Their white cell counts may not rise immediately due to an infection or inflammatory process, but the CRP will be high. So if the CRP is gradually coming down, that will be a good guide to say that the patient is responding to treatment, maybe the antibiotics, or that surgically you have removed the offending organ or that part. So that's a very good tool, full blood count, CRP. And then other tests may be helpful. If the patient is in severe sepsis, liver functions may go up, renal functions may be impaired, but those are late things. But usually full blood count, CRP will be adequate for acute inflammatory conditions. ESR generally we do for chronic conditions like TB, inflammatory bowel disease, and so on and so forth. Then diagnosis through imaging. So the least the imaging tools, the least invasive, cheaply, frequently available one is the ultrasound machine. It is available in almost all hospitals in Sri Lanka now, may not be in the peripheral units, but starting from district hospital upwards, I think, is equipped with the ultrasound scan. So ultrasound scan helps to, diagnose the area. Maybe, sometimes may not be a good tool for appendicitis, but it can help exclude other conditions in a young female, like a twisted ovarian cyst or a tube ovarian pathology. Whereas, then you think, okay, fine, then those things are not there. There is no tubal pregnancy or anything like that. You can exclude a pregnancy as well. And you do a urine test and exclude pregnancy, and may then consider, okay, this probably is appendicitis. So sometimes diagnosis through exclusion, not actually diagnosing, but you exclude the other condition. This is probably appendicitis. So not all patients with appendicitis will have full-blown pain and tenderness and all of that guarding rigidity fever. They might be having just a catarrhal sort of inflammation-like thing in the appendix. So in such patients, excluding other conditions will help in the diagnosis of the inflammatory condition. So some things I forgot. The patient may be febrile, tachycardic, shallow, fast breathing, particularly when there is peritonitis. They can't. Usually what we breathe with the help of the abdominal muscles, the diaphragm. So the abdomen moves freely during breathing. But when there is an inflammatory condition in the abdomen doesn't move. Not necessarily in the lower abdomen, but if there is upper abdominal inflammation, the abdomen will not move freely. And the patient will therefore do rapid, shallow breaths. So they'll be slightly tachypneic. The features of dehydration, like dry mouth, dry, maybe slightly sunken eyes. The patient is not passing much urine, oliguric, maybe occasionally anuric. The patient has a septic appearance. For an experienced surgeon, immediately the patient, he may be able to see, okay, this patient is septic. This patient is in an inflammatory, sort of infectious condition. Not infectious, rather he's having a septic focus somewhere. So we can say that by looking at the patient says, you too, with time, will be able to do that. So, and guarding and rigidity. Guarding, rigidity, these are slightly different things. Guarding is something voluntary. So the patient will, let's say for an example, if the patient is having appendicitis and you press in the right iliac fossa over the McBurney's point, the patient knows that it's going to cause pain and they will tense their abdominal muscle. That is called guarding. Whereas rigidity is different. Because of the inflammation of the peritoneal lining and that inflammatory process, the muscles go into sort of a contraction, and that is rigidity. With experience, you can differentiate between guarding and rigidity. Guarding is something that you can, get the patient to sort of distract. You can distract the patient, maybe, talk to the patient or ask the patient to, pull the thumb of one hand with the other one, and then distract the patient and then gently get rid of guarding and examine. Whereas rigidity, that will not happen. It is not a voluntary phenomenon. So these are some of the pictures that I have taken from the internet. So you can see these symptoms of peritonitis. Sometimes the patients having inflammation in the pelvic region can have diarrhea because of inflammation of the rectosigmoid colon. Whereas the other patients, because of inflammatory process, may causing, let's say for an example, a perforated diverticulitis and divertical abscess. The abscess pressing on the bowel can cause the patient constipation, and the inflammatory process within the abdominal cavity can cause constipation. Likewise, so not all patients will present similarly, but fever, tachycardia, tachypnea, abdominal pain, guarding, rigidity, these are salient features of peritonitis. So I told you about neutrophil leukocytosis, that is full blood count. You will see the white cells have gone up. The usual levels are between 4 to 10 or 4 to 11,000. If the white cell count is 15,000, CRP is about 50 or 75 or 100, and there is patient having right iliac fossa pain, vomiting, fever, probably appendicitis, or the patient having upper abdominal pain with history of NSAID use, possibly because of a perforated peptic ulcer, history of constipation, maybe bleeding per rectum, and this patient is having abdominal pain, now most localized to the left iliac fossa, or now generalized abdominal pain, maybe because of perforated diverticular disease, or may even be a perforated large bowel colonic cancer. The age of the patient is also important. Like, you're not going to see a perforated colon cancer in a 18-year-old or a 20-year-old. It's very, very rare. But, a 70-year-old man with left iliac fossa or central abdominal pain, general abdominal pain, maybe because of perforated diverticular disease, or more commonly a perforated rectosigmoid malignancy, likewise. So if you do a blood, what do you call this, ABG, that is arterial blood gas analysis, the patient will show acidosis with there may be associated hypokalemia and hypernatremia. I went through this imaging. Yes, something I forgot is the erect chest X-ray. If you are suspecting a perforation of a hollow viscus, like the stomach, small bowel, duodenum, or large bowel, if you are suspecting a perforation, if you do an erect chest X-ray, you will see gas under the diaphragm, particularly under the right hemidiaphragm. You can sort of confuse yourself with a gastric bubble if you look for gas under the left hemidiaphragm, but gas under the right that is between the liver and the right dome of the diaphragm is not something that you will see. There may be gas in a patient who has had recent laparoscopy, that in the last 2-3 days, or who has had an open surgery recently. There may be some gas in the abdomen, but in a virgin abdomen, there can't be gas under the right hemidiaphragm. If you do an abdominal X-ray, usually we don't do abdominal X-rays nowadays, but you will see edematous dilated bowel loops. We do abdominal X-rays, supine X-ray abdomen, for patients who are suspected of bowel obstruction. But in most hospitals nowadays, CT scans are available, or patients will be referred to institutions with CT scan. It's best to do a CT scan to diagnose a patient with bowel obstruction rather than just go in and do a full-length laparotomy. So you can still do it if the facilities are not available and the patient is not stable for transfer or wait for the CT scan. You don't even need to do any of these investigations. If you suspect the patient to be having severe peritonitis and patient is becoming unstable, you can't take a really unstable patient with a lot of inotropes to the theater and open up the patient. That patient is not going to make it. So you have to stabilize the patient and then take to the theater. There are certain instances where you think, no, if I keep this patient further, it becomes more unstable, and then therefore you take the patient to the theater. So these are kind of senior judgments. So you will have to get the senior registrar or the consultant to attend to these patients. Ultrasound abdomen, I said, probe tenderness, collections can be diagnosed, particularly, say, around the appendix, there can be collections. There can be collections in and around the pancreas if you're diagnosing pancreatitis, likewise. And of course, diagnostic peritoneal lavage and laparoscopy. These are invasive procedures. Of course, diagnostic peritoneal lavage is where you put a needle and aspirate, send the aspirate, and then you infuse the peritoneal cavity with maybe 1 liter of saline, and then you aspirate it out and send it for analysis. If there is blood or white cells, likewise, we can analyze what sort of an inflammatory process is going on inside the abdomen. That is called diagnostic peritoneal lavage. And so it is positive, and operative exploration is warranted if there is 10 ml of blood, 10 cc of blood, and then maybe 100,000 RBCs, that is under the microscope per cubic millimeter, or if there are 500 white cells per cubic millimeter, presence of bile, bacteria, or food particles. Now, in the peritoneal cavity, there can't be bile. So if there is bile, that means there is a perforation either in the extrahepatic biliary duct, or in the liver, or in the gut. So there can't be bile. Of course, bacteria can be there if there's a spontaneous bacterial peritonitis, but usually bacteria migrate. Then food particles, say for an example, capsicum seed, peritoneal cavity. If there, that means there's a perforation in the gut. Amylase levels more than 75. That is also diagnostic. Amylase can leak into the peritoneal cavity through a perforation in the gut. Amylase is secreted by the pancreas into the duodenum. It goes down along the food into the small gut, into the jejunum and ileum. So if there is a perforation somewhere, this will leak into the peritoneal cavity, and presence of amylase is an indication of a perforation. Bilirubin, an alkaline phosphatase. Of course, if you suspect and the patient is stable, you can do a laparoscopy. If the patient is unstable, might as well go in for a laparotomy or maybe, there are several types of incisions that we can do. We can do a midline transfers, McBurney's, Rutherford Morrison, likewise Cocker's incision. There are many incisions of the abdomen. You'll have to open the abdomen and then get rid of the culprit. So that is sort of the other end of the spectrum, where you'll have an invasive sort of diagnostic and therapeutic option. Treatment at your level, get cannula into the patient. Once you put the cannula, you tell the nurses, at the same time you take blood for culture, you take for blood for full blood count, CRP, and the other necessary tests like maybe liver functions, maybe renal. We'll have to probably do serum creatinine as well in a septic patient. So these you have to do, and then hydrate the patient. You may have to give fluid boluses if you think the patient is dehydrated. And then you start empirical antibody, a broad spectrum antibiotic, maybe coamoxiclav, that is amoxicillin clavulanate, or maybe tazobactam piperacillin, likewise. So combination. Always there'll be hospital or national guidelines on antimicrobial use. Refer these things. You you can ask your senior colleagues, but yourself you also refer, and that will fine tune and make you a better patient, because things evolve. What we started as interns are no longer used actually nowadays, those antibiotics, and things have evolved. The organisms have also evolved. So have the drugs. You have to correct the acidosis, maybe give bicarbonates, correct the fluids, electrolyte imbalance, and then if there is hypokalemia, you may have to treat that. And then the supportive measures, like put an NG tube. If you suspect the patient to be having a perforated peptic ulcer, you can suck out the gastric contents and reduce the peritoneal contamination. Put a urinary catheter. It is important to measure the urine. Of course, not every patient with peritonitis will require urinary catheter. For an example, early acute appendicitis, no need to put a catheter in this patient. You can ask the patient, a young fit patient, who is not dehydrated, no need to put a catheter. But an elderly patient who is dehydrated or having other comorbidities, it may be important to put a urinary catheter and measure the input and output of that patient. So definitive treatment almost always requires surgery. So that's about it about peritoneal contamination, peritonitis. And I have touched on these areas. Oh, one last word about laparostomy. Laparostomy is to go into the abdomen through a midline opening and remove the sort of the culprit or the offending organ, or maybe attend to the perforation. And thereafter, when the surgeon realizes that there is too much of inflammation, bowel edema, bowel distension, and it's not safe to close the abdomen, because once you close, it causes extra sort of increase intra-abdominal pressure. That is called abdominal increase intra-abdominal. It's called abdominal compartment syndrome. In such situations, the surgeon may very rarely, though, consider managing the patient as a laparostomy. You may come across, only a few of you all might come across a patient with a laparostomy during your career. So that's about it, about the management of, broadly about the management of peritonitis. This is like teaching you to play cricket or on via the internet. You have to get in, go and play that at the grounds. So likewise, you know, when you go into the in your internship, you will come across these patients, and I hope the little knowledge I try to impart on you will be helpful to manage your patients with peritonitis. Any questions? Can I move on to the next talk then? If any of you all want these presentations, I can send it to the College of Surgeons or Roshan, and you can get it. Hear me, right? Nobody's talking. Hello?
We can hear you, Dr. Ranu. Yes.
Right, super. Okay. After a while, you wonder whether you are just talking to yourself. Right. This is my other lecture. I'm going to combine both them because Dr. Nisanka Jayawardena is unwell. So this is preparation for endoscopy. When I was an intern, there was only one patient who had a flexible sigmoidoscopy. And where I did my internship at that time, we did not have these endoscopic, that was in 2004-5. In Putlam, we did not have this luxury of an endoscope. There was a flexible sigmoidoscope, which, you know, it was not a video scope, you know, where we had to place our eye on the lens and then maneuver the endoscope into the rectum and the small and sigmoid colon. That only the surgeon performed. Only one patient was performed. That's the for my entire internship, 6 months or 6 months. But things have changed. Things have evolved. So endoscopy is something that surgeons and the gastroenterologists in Sri Lanka, they frequently perform on a weekly basis. Some do it on a daily basis. So it's something which is very important now. As doctors, you must be able to prepare these patients. As a house office and intern, your job is to prepare these patients for endoscopy. You are not expected to perform. Maybe, you know, if you're really good and keen and you're interested, your consult might give you 1 or 2 patients to scope, particularly upper GI endoscopy towards the end of your end of your 6 months. So good luck with that. So endoscopy, it's a procedure used to view and operate on the internal organs and vessels of the body. So endoscopy is actually a broad term, a large umbrella term where under which lots of procedures are included. It's not only visualization of the gut or the mouth to gut, the alimentary tract. It encompasses arthroscopy, hysteroscopy, cystoscopy. That is, you know, cystoscopy is looking at the bladder. Hysteroscopy is looking into the what do you call this? The uterus, uterine cavity, and then arthroscopy is visualization of the joint cavity. So likewise, there are many endoscopies. You can do cholecystoscopies, rhinoscopies, ureteroscopies. Likewise, lots of scopies. So the word endoscopy is derived from the Greek word endo and scopine, that meaning look to see inside. Endo means inside, scopine means to see. So medical endoscopy came into sort of use with the invention and application of fiber optic technology. So read what fiber optic technology is. and where you use thin fiber glass fibers to transmit light and to and from the organ view. So once you send light, it gets sort of reflected, and these are transmitted via bundles of thin glass fibers called fiber optics. And almost 100% of the light that enter these glass fibers are transmitted through them. So as I said, it is a term generally mistaken for visualization of the digestive system. It is not so. It has a wider scope. As I told you, arthroscopy, I forgot to mention bronchoscopy, that is looking into the trachea, the bronchi, and the primary, secondary, and the tertiary bronchi. You can visualize them. And then the visualization of the gut. Laparoscopy is also a form of endoscopy where you do keyhole surgery and operate or look inside the peritoneal cavity. Hysteroscopy, cystoscopy. Then sometimes we do cysto-ureterorhinoscopy. That is, a single scope that goes up to the renal pelvis through the bladder into the ureter and the renal pelvis likewise. So, but in my talk, I'm basically going to talk to you about upper GI endoscopy, colonoscopy, and sigmoidoscopy, because the other varieties are generally for specialized units, and you as house officers will most likely will not be preparing patients for unless you join a university surgical unit where there is a urologist. You may have to prepare patients for cystoscopy, but if you're doing a medical appointment, you may have a consultant pulmonologist who does bronchoscopy, and you have to prepare patients for bronchoscopy. But generally for surgical trainees, or rather surgical house officers, what you need to know is upper GI, colonoscopy, and flexible sigmoidoscopy. So what is upper GI endoscopy, or OGD? OGD is esophago-gastro-duodenoscopy. In other words, you can say EGD. That is the American term. They don't use the O in front of E. So OGD, EGD, upper GI endoscopy. So gastroscopy, sometimes they shorten it for gastroscopy. So these are the same. This is actually the same thing. So we pass a long tube with fiber optics down into the down through the mouth, through the you go in through the piriform foci and through the cricopharynx into the esophagus, and then down the esophagus through the gastroesophageal junction into the stomach, and through the stomach pylorus go into the first and the second part of the duodenum. Usually we visualize up to the second part of the duodenum, but with difficulty we can go up to the third part of the duodenum. There are modifications of this OGD. That is, one is called enteroscopy, where it is a longer tube where you have to sedate the patient deeply and go into the small bowel. You can go into the small bowel. It's a very long tube. It's generally not performed nowadays, mostly replaced with a capsule endoscopy, which is a capsule containing a small camera that is followed, and you have a device that is attached to you that tracks and records the images that taken through the capsule camera. So that is that's something that you don't need to worry about. So endoscopy, usually this is done as an outpatient procedure, maybe with mild sedation, or most patients in Sri Lanka are not given sedation. But in the developed world, they frequently request sedation. So it's okay practicing sedation. It's good for the patient. They don't like, nobody likes a long tube, choked down your throat into your stomach and insufflated. It's not a nice feeling. So sedating the patient is a good option. You can have, you also will be relaxed as a surgeon. So you will have to prepare the patient for sedation. As you can see, the patient will be in the left lateral position for this. So to visualize the stomach, it has to be empty. I will tell you about how, first of all, I forgot to mention. So doing upper GI endoscopy, there may be, the indications can be broadly divided into diagnostic and therapeutic. Diagnostic, when the patients with dysphagia, maybe because of esophageal malignancy, maybe acid strictures, or dinophagia, where there is painful swallowing, maybe a fish bone stuck in the upper esophagus. dyspepsia because of gastroduodenitis, belching, recurrent belching, heartburn, retrosternal burning sensation. Likewise, you can do that. And do a biopsy if you suspect a malignancy, gastric cancer, esophageal malignancy, you can do biopsy. And therapeutic, when you intend to do a small procedure, not small sometimes, maybe a stenting of esophageal malignancy in an inoperable patient, retrieval of a foreign body. Frequently, children come after swallowing coins, maybe metal objects, pieces of toy, maybe nuts and bolts. These things you'll have to retrieve. So these are therapeutic. Glue injection for gastric varices, banding of esophageal varices, insertion of a peg. Peg is a percutaneous endoscopic gastrostomy. That is where you put a tube instead of a nasogastric tube. We can directly put a tube into through the abdominal wall into the stomach for feeding, a larger tube than the NG tube. When that is convenient for the patient there's tube hanging from his face, he saw her face, they can go into the society while having a tube for feeding in the abdominal wall. So these are therapeutic. So endoscopy is used for diagnostic procedures, therapeutic. Sometimes we do diagnosis and do therapy at the same. So both diagnostic and therapeutic value. Procedure is an outpatient procedure with or without sedation. Give me a moment. It's an outpatient procedure with or without sedation. As I said, the patient has to be fasting for at least 6 hours. It takes 6 hours to empty the stomach. So if there is food particles in the stomach, you will not be able to properly visualize. There is also the risk of aspirating the food into the patients, because if the patient sort of suddenly vomits or gags or throws up whatever is contained, there is a risk of it going into the respiratory tract. And therefore, you have to get the patient fasted. This is your role as a house officer. Tell the patient who are planned for OGD that you need to be fasting for 6 hours. So most often the lists start at 8 o'clock, or if it's an afternoon list, it's at 2 o'clock. So you tell the patient, you can eat till midnight, and after that you fast. If the patient is having a OGD only, okay. Sometimes patients may have OGD and a colonoscopy. In that case, of course, the feeding will be different. Anyhow, the last 6 hours, the patient will be fasting. If you are suspecting gastric outlet obstruction because of a tumor in the pyloric region, then these patients will have delayed gastric emptying. So you may have to keep the patient a bit longer for fasting, maybe 10 hours, 12 hours, sometimes supplemented with the IV drip, these patients, and you must, these of course, whether the patient is having loose teeth, false teeth, of course, the nurses will attend to this. But as a doctor, it's good that, if you can warn the patient that he should leave the dentures, remove the dentures before the procedure. There is a risk of, pushing that into the stomach, or it may even to be the respiratory tract. So it's generally done under local anesthetic spray, 10% lignocaine spray. And if sedation is used, the patient can't drive home. So these are important. Somebody else has to drive that patient home. They can't be discharged alone if sedation is used. Otherwise, they can go home alone after having a upper GI endoscopy. When I was an SR, I had this procedure done on me. I went to work fasting, and my colleague did the endoscopy, and I continued to work that day. So it's not a very invasive procedure. So consenting for the procedure, generally the explanation is done by a senior person. But when there's a lot of patients, you will be expected to consent the patient for the procedure. So you need to understand what upper GI endoscopy and explain the procedure and the possible complications of this. So preferably consenting, at least explaining, should be done by the senior colleagues, and the written informed consent can be taken by the house officer. Possible complications are aspiration, perforation, bleeding. Post procedure, you'll have to warn the patient. You will feel a bit, that your throat, you will feel as if it's scraped for a day or two. And And immediately after the procedure, they cannot eat or drink for about an hour or two, because a local anesthetic spray will linger, the effect will linger for about an hour or two at least. So you need to warn this. And post procedure, you must look for undue pain in these patients. You know, if the patient is after the procedure, patient should not be in pain. If the patient is having pain, it may be because of a perforation or something like that. So, and signs and symptoms of bleeding, particularly after banding of esophageal varices, the patients or gastric glue injection for gastric varices, or upper GI endoscopy to control bleeding from duodenal perforations. Posterior duodenal perforations erodes into the gastroduodenal artery, and the patient may bleed into the gut. So, and these patients, you will have to be particularly aware, and you have to be sort of aware of these possible complications. And evidence of perforation. Upper GI, you know, if there is a perforation in the esophagus and there is gas leak into the sort of adventitia, the patient will develop surgical emphysema of the neck and the upper chest area. So, you know, if you feel crackles of the skin, that means there is possible perforation, and you will have to sort of inform your senior colleagues, the registrar, senior registrar, or the consultant, that this patient after an upper GI endoscopy is having surgical emphysema. And certain patients, usually these are outpatient procedures. The patients come directly to the endoscopy units. In certain hospitals, they admit the patients for various reasons, but it doesn't require an admission. But if admit, and after certain procedures like stenting, banding, clipping of bleeders, the patient may have to stay overnight. Otherwise, the patient, it's an outpatient procedure. Patient can go home after the procedure. So that's about it in the upper GI endoscopy done under local anesthetic. So the dosing of the spray, you know, is important. Each spray delivers, I think, 10 milligrams of lignocaine. So the maximum dose is 200, they say, but you know, usually we use about 6 to 8 sprays in the throat, and this should be within the approved levels. It's not toxic usually. And then a word about flexible sigmoidoscopy. So in the past, there was shorter scopes, sigmoidoscopes, but nowadays we use the colonoscope to perform the sigmoidoscope. The sigmoidoscope is a shorter one because we did not have to visualize the whole large bowel. There was a shorter scope. Nowadays, that's not invented. The entire colon is visualized with the colonoscope, and the same thing is used to visualize part of the large bowel. That is the left colon. Usually flexible sigmoidoscopy, meaning we visualize the left colon of going up to about the splenic flexure. The patient will be, it's again done as an outpatient procedure with or without sedation. We can give a bit of sedation because it can be a bit uncomfortable, particularly with, you know, when we advance the scope, we insufflate air into the large bowel. That can distend the abdomen and cause a bit of a discomfort for the patient. So we generally give some sedation in the form of midazolam, about 1 to 2 milligram a stat or a repeated dose, along with sometimes fentanyl, that is given as an analgesic, 25 to 50 milligram. That is what we usually use. So the patient is in the left lateral position during this procedure. So how do we do it? Again, outpatient procedure with or without sedation, no need of fasting. You're going to empty the left colon using enema, phosphate enema. We insert 1 or sometimes 2 to evacuate the stools in the left colon, that is the descending colon, sigmoid colon, and the rectum. And then immediately, about half an hour later, you do within the next half an hour, you do the procedure. You insert the enema, the patient goes to the toilet, and then the bowel is evacuated. Then you put the scope and you visualize. Usually we do this for left colonic pathologies like fresh bleeding per rectum. The patient is having fresh bleeding per rectum. You can get away with doing a flexible sigmoidoscopy without doing a full colonoscopy. Or for follow-up patients who have had, maybe a diverticular disease in the left colon, or maybe a polyp excision, or maybe the patient who has had neoadjuvant therapy for rectal cancer and complete responders, we can do a flexible sigmoidoscopy just to assess the left colon. Once again, if sedation is used, the patient can't drive home. These are important things as junior doctors, because the seniors will be busy with, managing the patients or maybe operating in the theater, whereas you will be discharging these patients home. So it's important to make sure that the patients don't drive home after sedation. And so you can't perform this if the patient is having excruciating, painful perianal conditions like anal fissures, perianal abscesses, perianal hematomas. These are also called as external piles. So these conditions, you can't, if you're having a painful fissure, you can't push a scope inside the anus, the patient will kick you. So these are conditions you have to examine the patients when the patients come to the ward for these things, whether they are all right to undergo this procedure, or you can just ask them whether there are any perianal painful condition. You don't need to do a rectal examination because it will be performed by the surgeon, but you can always do it for your learning experience. So while consenting, you must warn the patient there may be a little bit of blood, and there is a very rare chance of perforation. Well, not very rare, there is a chance of perforation during the procedure. So you have to warn these patients about bleeding and perforation. So bowel preparation, I said 1 or 2 enemas. Phosphate enemas, they contain sodium acid phosphate and sodium phosphate. What it does, it through osmotic activity, sodium phosphate, it increases the water content of the stool. It absorbs water into the gut and into the stools and causes rectal distension. The rectum is usually empty. So once the stools come down and distend the rectum, you get the defecation reflex initiated, and the patient goes to empty the rectum. So enemas are inserted by the attendants, the other auxiliary staff, maybe the nurses, or they are the ones who do it. But you can advise them how it is done. It is done in 2 positions, either in the left lateral position, or like in the photo in the picture it is shown, in the knee elbow position. It is best in the knee elbow, but not all patients will be able to stay in that position. But you have to warn the patient that once the enema is inserted, he will get the urge to go and defecate, and he or she should not run to the toilet immediately, but to hold the enema in the rectum for about 15 to 20 minutes for its action to occur. Immediately, if they go to the toilet, they will just pass the enema fluid. That's a waste then. So what they should do is they should hold. Once you empty the bottle into the rectum, they will feel the urge to defecate because it distends about 200 ml of fluid in the rectum. It will distend the rectum and they will want to immediately go to the toilet. But you must warn them not to go immediately, but to hold on and allow that drug to take action and make the stool softer and loose for it to move. And you must tell the staff doing the enema insertion not to, they have to do it gently because it can injure the anus or the rectum. So the popular brands available in Sri Lanka, Clean Enema, Fleet Enema, Micro Enema, these are the ones, you will be most often when it's not available in the government sector, you will be giving a prescription for the patient. This is happening, so this is happening regularly. So you will be giving a prescription. So unfortunately, you will have to sometimes mention the brand names, although reluctantly, because otherwise the patient will be in the wrong thing and there will be issues. So these are also things to consider. Colonoscopy. This is more an advanced procedure than flexible sigmoidoscopy, where you will visualize the entire colon. So I'm showing in this picture, as you can see, the scope is passed through the anus, the rectum, sigmoid colon, going along the descending colon, entire transverse colon into the ascending and the cecum. This is not a simple procedure. This is done by experienced hands, generally by the consultant or the senior registrar, rarely by the senior surgical registrar. Not senior registrar, but senior surgical maybe. As a house officer, you may not be able to do this. So, but you need to prepare the patients for colonoscopy. These patients are the most, this is where you have to get involved in patients' preparation more often than in upper GI and colonoscopy, because those procedures are simple and preparation is not that difficult. But for colonoscopy, the preparation is more detailed. So, as I said, we go sometimes into the terminal ileum. So we need proper cleansing of the entire large bowel. When we were surgical trainees, the only product available was clean prep, and we used to give 3 or 4 sachets. Each sachet dissolved in 1 liter of water, and the patient consumes these 3 or 4 sachets and complete it about 4 hours before the procedure. So if you are doing the procedure at 2 o'clock, they start early morning. At about 5 o'clock, they start, and then by about 12 o'clock, 11 o'clock, they finish the 3 or 4 sachets and empty the bowel. If you are doing it early morning at 8 o'clock, then the bowel preparation, we can do it the day before afternoon, or yes, we can split it and give one maybe in the morning. So split dose bowel preparation, where you don't give all 3 or 4 sachets in one go. You give 2 in the previous evening, and give 2 in the following morning, and then you do the procedure in the afternoon. So splitting is also accepted way of preparing bowel. So, however, the last dose of bowel prep, that is the last sachet of bowel prep, we have to start 5 hours before the procedure and complete that 2 to 3 hours before the procedure. So this is something that is important. The last sachet, that will be that will clean the entire colon. Then it will be sort of fully empty, completely empty for the procedure. And when you give the patient the dates in the clinics for colonoscopy, or the patients while on the ward, you must tell them that they should avoid high fiber diet, but take low fiber diet for 1 to 2 days. You must read what diet contains fiber, particularly the green leafy vegetables, nuts, and loofah, then Vatacolo, Kohila, that is Lesia, all of that. You must tell them to avoid these things. And some units, they use simethicone with bowel prep, simethicone, which helps eliminate bubble. Sometimes when this water, bile gets together, it forms bubbles, and then during endoscopy it becomes difficult to visualize the colon. Therefore, to eliminate these bubble formations, some units use simethicone. I personally don't use. So you have to be aware of patients with possible electrolyte disturbances, particularly the CKD patients, where you have to avoid certain types of bowel preparation. I'm coming to that. So colonoscopy, we use it to diagnose diverticulitis, cancer, Crohn's disease, that is inflammatory bowel disease, ulcerative colitis, adhesions, polyps, so on and so forth. So, and it may be therapeutic as well, particularly if you are putting a colonic stent, or if you're doing a polypectomy, or if there is a sort of bleeding area to say, particularly after the patient is having radiation proctitis, maybe burning that area. So the colonoscopy and flexible sigmoidoscopy can be used for therapeutic purposes as well. Bowel preparation, I've already mentioned. Entire colon needs to be cleansed. Low fiber diet for 1 or 2 days. Avoid nuts, green leaf.